Thank you very much. So I have the misfortune of following Dr. Amanoff, which is quite a large pair of shoes to fill, but I'll do the best I can. And I also have the misfortune of speaking to you about sleep right when your lunchtime meals are kicking in. So I'll try to be as entertaining as possible to keep things going. Okay, so one of the things that Dr. Amanoff had spoken about earlier today that I think is very, very important, and over my relatively brief career in the field of Parkinson's disease, that has come to light is the fact that a disease that we've considered to be a disease of motor symptoms is very, very far from that. And in fact, if you follow patients for an extended period of time, though you can initially make great improvements on their motor symptoms, over time you start finding that other problems become to play a much larger role in their disease and start affecting their quality of life more and more. And I think Bill Langston wrote a paper in 2006 describing the Parkinson's complex as what we see as sort of the substantia nigra, or the motor symptoms, but underneath that large iceberg is all of these other problems that comprise depression, cognition, problems with your bladder, problems with sleep, excessive daytime sleepiness, skin changes, all kinds of other things that come from the fact that Parkinson's disease affects your entire nervous system. And as Dr. Amanoff pointed out, this was described pathologically by Dr. Brock, who showed that, in fact, Parkinson's disease may begin further south in your nervous system and slowly work its way up, such that your smells function, bladder function, sleepiness function are all affected well before you ever get a tremor or stiffness or slowness, or before anybody starts noticing, hey, why aren't you swinging your arm quite as much? And so from that angle, I've developed a strong focus on sleep, and I'll spend the rest of the time today speaking to you about that. This is just an example before I move on, just to show you how many symptoms that patients with Parkinson's have. And in this audience, everybody here knows this already. But for our medical students and our residents, we use this tool to remind them, you need to ask about more than the tremor, because everything on the picture of this guy can affect our patients. And in reality, a lot of them can play a larger role in the quality of life of our patients than just the tremor or stiffness or balance can. So I'll speak about a limited spectrum of sleep problems, and feel free to ask me about other ones as they come up later, as these are sort of the most common ones, the ones that we find most troublesome to patients, and I'll work slowly through them. So the most common symptom that we encounter is patients that just feel tired. And even if they feel like they may have gotten a good night's sleep the night before, they feel just sort of exhausted during the day. And many patients have even reported that they, even before they were diagnosed with Parkinson's disease, started taking naps in the daytime, and they never had previously. Difficulty falling asleep is a problem for some patients, although a number of patients describe, I have no problem falling asleep, but I wake up after 3 hours and then I'm done. I can't go back to sleep, or I lay there for 2 hours and then finally I get another couple of hours of sleep. Dream enactment behavior, or acting out your dreams. If people don't know this, haven't seen this in the room, their spouse probably has. And I'll show you some videos about how this can be quite problematic for patients. Restless leg syndrome, or a creepy crawling discomfort feeling that you get in your legs when you're trying to go to sleep, is not uncommon in Parkinson's. And there's some debate about whether obstructive sleep apnea is more or less common in Parkinson's patients, and what role it plays in fatigue. So I'll sort of go through those one at a time. So daytime sleepiness in at least one paper is described as occurring in between 35 and 60% of Parkinson's patients. And I think, based on my time in our clinic, that's about accurate. If we actually ask our patients, are you tired, are you sleepy during the daytime, that number is pretty high, the number of patients that will say yes, as compared to non-Parkinson's patients. Just sort of the average person in our society is a little bit more tired than probably they were years and years and years ago, just because of all the demands, but Parkinson's patients far exceed this. And a number of them consider sort of lack of energy to be the most disabling symptom. So though you have a tremor, you're so tired you don't really have the energy to do stuff during the day, and that impacts the quality of life more than maybe the tremor does. So one thing that a number of researchers are starting to look at now is the fact that patients may start napping more frequently before they ever get diagnosed with Parkinson's. So if you think back in your own mind about sort of, well, did I start getting tired or napping more than I ever did before, even before I developed Parkinson's disease, it seems like the answer is maybe yes, maybe that does happen with some frequency. This excessive sleepiness may worsen as the disease progresses, and that may be related to the disease itself, and it may be related to the fact that we give you a ton of medicines that make you sleepy, and that's something you have to let us know as well, because a lot of the medicines that we use to help with the motor symptoms make people tired. And just as an aside, a lot of times you have to bring this to the attention of your doctor. One of the things that I do is, I think we're very lucky in the Bay Area. We have so many good Parkinson's or movement disorders neurologists. I go up and see patients in Anchorage, and there's no movement disorder specialist in Anchorage. And the first time I went, nobody had ever asked 100% of the patients that I saw that day about how tired they were. And everybody sort of said, oh yeah, I'm tired all the time. It was great for me because I could fix the problems, but it is something that we aren't taught in medical school. This is a big issue in Parkinson's disease. So it is something where if somebody hasn't asked you and you feel it, bring it up to your doctor because we can help. So what causes the tiredness? I put medication side effects on the top because it's something, we're always taught, first, do no harm. So I think, we always have to keep in our minds, when somebody says, I've had Parkinson's disease for a little while, it's starting to affect my quality of life, I'm not really living in the mainstream of my life anymore from a motor perspective, our response is, well, maybe we should try you on a medication, Mirapex or something like that, but we have to bear in mind that our goal is to make your quality of life better. So then if we make that tremor go away, but then you're still not on the golf course because you're taking a nap all day, then we haven't really improved things. So we really need to keep that in mind. Difficulty with sleep hygiene. I think it's very common that patients with Parkinson's disease are tired, so then they start napping in the day more, and then they start napping in the kind of late day more, so then it becomes harder to go to sleep, and you sort of get this phenomena of, I sleep a couple of hours at night and a couple of hours in the middle of the day, and it's really hard for your body to keep that good circadian rhythm, and that's something that we can work with people on. Difficulty falling asleep, so if patients have like restless leg syndrome, which I'll talk about in a minute, or their medications aren't being titrated appropriately at night, so you feel off and kind of uncomfortable, then if you can't fall asleep, you may be tired the next day. Likewise, if you can't stay asleep, you wake up in the middle of the night, your medicines are totally off, you're kind of sore in the middle of the night, or you're waking up 100 times because your bladder is acting up, as Dr. Dang will talk about later, then you may be tired the next day as well. There's an arguable contribution to obstructive sleep apnea, which is sort of what I consider to be sort of an epidemic in our population, which is closely related to obesity. That being said, in Parkinson's patients, they're maybe more likely to have obstructive sleep apnea in spite of having a completely normal body mass index. So being a normal sized person, just because you have Parkinson's disease and maybe have motor control problems in your upper airway, you may be a little bit more likely to get Parkinson's, though some recent literature suggests that that is not actually accurate. One of the things that I think we overlook in terms of its role in fatigue is depression. The percentage of Parkinson's patients that have depression is sort of upwards of 50% in my experience at some point. And if you are depressed, you A, don't sleep as well, B, wake up in the night more, and C, feel lethargic and sort of less energetic. And so, doing the right things to treat depression and sort of identify that as a contributor is an incredibly important thing to focus on as well. And finally, I think one of the harsh realities is that Parkinson's does affect multiple parts of your nervous system, and one of those is what I sort of call the sort of alertness or energy center. And I think in some patients, even though we've cleaned up all of those things, we've done everything we can with medications and made sure that we're not affecting their sleepiness, there is a role that Parkinson's disease plays probably in the lower part of your brain that predominantly can just make you tired regardless of what we do medication-wise. So what medications make you sleepy? I think this is an important thing to note. Most of them is sort of the answer. Selegiline and rasagiline are kind of clear. They typically will not make you sleepy, and in fact, sometimes selegiline can give you a little bit of an energy boost. The same is true with amantadine. Sinemet will make about 14% of people tired or have excessive daytime sleepiness, according to the original studies. Whereas Mirapex and Requip and the other dopamine agonists, Nupro, none of them are sort of immune to this, cause excessive daytime sleepiness in around 30% of patients. And this can range from just feeling tired. A lot of people describe, I take my Mirapex and then I get this sort of wave of fatigue that comes over, and which is one thing. And some people will say, well, I just take a nap for a little bit, and then once that wears off, then my medicine works okay, and I'm all right. Other patients can have sleep attacks, which are almost like narcoleptics, where they just sort of, boom, out of the blue, they're in the middle of a conversation, and next thing you know, their head's in their bowl of cereal or whatever because they fell asleep. And those can be particularly dangerous, and if you're operating heavy machinery. In addition, medications like Artane, which is a medicine that is sometimes used to help tremor in Parkinson's patients, is definitely associated with tiredness, not to mention constipation and what we call cognitive blunting, or memory problems. So why can't people fall asleep? Than anybody else to have insomnia. But they are way more likely to not be able to sleep through the night or wake up a couple of hours later. So one of the reasons can be restless leg syndrome. So this is sort of, or at least historically, has been all the rage in the media. People have seen pictures of spiders crawling on your legs in commercials and stuff like that. And it's sort of can be this creepy, crawly sensation on your legs that makes you feel horribly uncomfortable, and this need to wiggle your legs around. I'll show you a video of this in a minute. And obviously, it's hard to fall asleep if you have that feeling. And we think this is more common in Parkinson's patients, though it's a little bit unclear. Another problem is too many daytime naps, as I discussed, particularly late in the day. If you do need to nap, which a lot of people with Parkinson's do, you should try to nap in the early afternoon and make that your last nap of the day. And try not to nap for like 4 hours, make it more like an hour maximum. And that way you'll sort of still have your anchor time at night, which is your sort of large bulk of sleep. Poor sleep hygiene. So what we mean by that is, eating a giant meal right before you try to go to bed, drinking coffee in the late afternoon, having a dog sleeping in your bed with you, having a partner with REM sleep behavior disorder sleeping next to you. Any number of things that can make the bedroom a bad environment for sleeping. One of those things is having the TV in your bedroom, which some people sort of boo at, but I think if you do have sleep problems, one thing to do is to get the TV out of the bedroom. Depression can make people have difficulty sleeping, and as Dr. Dang will talk about, and I mentioned earlier, bladder or prostate problems. So I think I've talked about most of these already, but typically, as a rule of thumb, you should use your bedroom for sleeping and sex pretty exclusively, and you should do all of your sort of active activities earlier in the day. Exercising is important to help you sleep at night, but it's important that you do it earlier in the day, meaning no exercise at sort of 9 p.m. And you should also not nap later in the day, I'll reiterate, and not drink caffeine late in the day. And there is a role that eating giant meals sort of, in the late evening plays. So what do we do about it if patients sort of come in and say, I'm tired? The first thing we do is we run through all of these other things that can cause the problem. What medications are they on? Or did you notice that this started when we started you on Requip or Cinemet or whatever? We'll make sure you're not hypothyroid. We'll talk to you about depression and exclude depression as a cause. But after all of, and we'll ask you if you snore or stop breathing in the night. We'll ask you if you wake up, repeatedly to use the bathroom in the night. And after all of those things are clear, if even all of those things, once we've sort of addressed all of them, people still feel tired, what can we do? One thing is if you can't stay asleep, which is a more common problem than can't fall asleep, is we'll use some sleeping aids. So sometimes people will use antidepressants that are sleep-inducing. So trazodone is one of those that a lot of people are on. It's not my favorite medicine because it can make you feel lightheaded or dizzy when you stand up sometimes. And its half-life is very long, so it kind of lasts into the next day. A medication called Remeron, or mirtazapine, is an antidepressant that's kind of sedating, so sometimes people will take that at night. And then otherwise, there's reasonable safety data for older adults taking things like Lunesta, Ambien CR, and those are probably a lot safer than the older benzodiazepine drugs that some people take. And so sometimes we try to use those, and we'll try to use the slightly longer acting ones, because even though most of the time those pills are designed to get you to sleep, they're designed to wear off quickly, whereas the Ambien CR and the Lunesta, for example, last a little bit longer. And most Parkinson's patients will fall asleep fine when they take their Ambien anyway, and then it would wear the regular Ambien, and then it would wear off by the time they woke up in the middle of the night regardless. In addition, sometimes there's a really short-acting sleeping pill that only lasts about an hour that we can give patients to try in the middle of the night, which can help them get back to sleep. That's sometimes helpful. One of our favorite things to do is to give patients a dose of controlled-release Sinemet at bedtime. This helps it sort of them stay on overnight so that they can sort of move around in bed a little bit better and have more comfortable sleep. Of all the things that we've done to help people's sleep and sort of quality through the night, adding this ambient or adding the controlled release Sinemet is sort of one of the low-hanging fruit things that we always sort of feel like we've hit a home run when we do that. And otherwise, if all of those things prove to be ineffective, sometimes we'll look at other stimulant medications, things like Provigil or modafinil. Now Nuvigil is on the market, which is sort of like Provigil once it's going to lose its patent. And otherwise, rarely will people try medicines like Ritalin, et cetera. So I'll change gears a little bit and talk about dream enactment behavior. Does everybody in the audience know what this is? Has anybody slept next to this guy before? So this guy is sound asleep in REM sleep or dreaming sleep. And he's dreaming that he's getting attacked by snakes, and he's hitting them off with rocks. So you can imagine if you were this guy's bed partner, it would be relatively unpleasant. So I'll jump through this one. I have one more of these here. Maybe. There we go. So these videos are from a guy psychiatrist at the University of Minnesota, Carlos Schenk, who first described this disorder, or at least is credited for. I think I've seen these videos like 100 times. I still can't get enough. So these range in, the reality is we always pick sort of the most dramatic videos to show people. Behaviors range from sort of small amplitude movements, sort of jerks or, quick punches in the night, to screaming out, loud vocalizations. And I've had ranges of patients, from doing all kinds of things, from falling out of the bed to I had one lady who her kids used to make fun of her because she would sleep in a recliner in the living room, and every time she would just be playing mahjong in her dreams. And she was so disabled that they would try not to wake her up because she really loved playing mahjong, and so they didn't want to destroy that for her. So one of the things that's really interesting about REM sleep behavior disorder or dream enactment behavior is that we think it's one of the most specific predictors of developing Parkinson's disease. And in fact, people have been described as having these dream enactment behaviors up to 20 years in advance of having Parkinson's disease. And this gives us a window of, if we do ever develop a neuroprotective therapy or a therapy that we think is really promising, if we could isolate these patients or find patients that had REM sleep behavior disorder, then that would be great, because if we know that Parkinson's disease really is starting 15 years before you ever get your first symptom, and we could slow it down then, you may never notice. The problem is it's hard to find people, because oftentimes when these are relatively mild, you don't show up to the doctor and complain about it. And so, though it's really interesting, that we worry that we wouldn't find enough patients to use this as an effective way of finding preclinical Parkinson's patients. Um, but if you do have Parkinson's disease, it's about 50% of patients do report this happening. And it can be, obviously, in these videos, disruptive to both the patient and the bed partner. That being said, if if these patients were sleeping on a mattress on the floor and never were woken up by their bed partner, they would not remember that it ever happened, and the quality of their sleep would be totally unaffected. And so, meaning they still get good quality of sleep, they're going straight through REM, just like you or I do, but their motor symptom is their motor center in their brainstem that cuts off all their movement while they're dreaming that most of us have is wiped out by Parkinson's. So when I dream about getting chased by a lion, I may wake up with a start or a startle out of fear, but I won't move around because that motor control center is intact for me. Whereas Parkinson's patient, that gets wiped out by the Parkinson's, and so they really are doing the motor part of their brain is really doing what they're dreaming about. So that being said, this is easily treatable. A medication called clonazepam is about 90% effective at treating, which has its own side effects, and depending on the patient, we think about whether or not to use this medication, but when we do use it, it's quite effective. There's newer data showing that melatonin, which most people know about from jet lag, is quite effective in treating it, although I think the literature is a little bit more promising than my clinical experience has shown. But it's always worth trying because it's over the counter, and B, it has very few side effects. Other medications like Seroquel can sometimes be used and if we really are struggling with the other medications, but obviously that medicine has its own side effects. The other things to note are dopaminergic medicines like Sinemet or Mirapex delay your REM sleep and reduce the amount of REM sleep you have. So if you don't have REM sleep, you're less likely to do this. So arguably, they're sort of a treatment. The other thing is environmental modification. So making sure you don't have, your Chihuly exhibit right next to your bed or whatever. So you swing and knock that off. And in fact, in the first case that Carlo Schenk described of this disorder, he had a gentleman who was so bad that he would run out of his bed in the night. And so every night he would take a rope and tie it through his belt loops and tie it to his bedpost to keep him from crashing into the wall, which fortunately 1 milligram of clonazepam is a much more effective treatment than that. So I'll move on and talk about restless legs, which are arguably present in about 20% of patients with Parkinson's disease. The problem with this is it's hard to really differentiate. Is it really restless legs, or is it the cramps or the Charlie horses that patients with Parkinson's get? And the reality is almost 100% of Parkinson's patients will tell you, I've gotten those Charlie horses and cramps, and they're more likely to happen at night, and if I stretch out my leg and move around, they go away, which is exactly the same diagnostic criteria for restless legs. So it's kind of hard to tease all that out. That being said, the medications to treat it, typically the longer-acting dopamine medicines, are the same. And so if we treat your Parkinson's more effectively, or if we're treating the restless legs, so be it, we've treated it, and people tend to sleep better. Typically, moving around is helpful for them as well. I'm not sure why I have this video. It's just a guy being really uncomfortable and moving his legs around. And so it's not uncommon that patients will be so uncomfortable they'll get out of bed and pace around the room or do a bunch of exercises. So that being said, I had to go all the way to Innsbruck to get this video, it looks like. So one thing, just as an aside, we always make sure patients don't have anemia, which can be a common cause of or an uncommon cause of restless legs, but can represent other diseases going on underneath. So we always like to, if we do see somebody with restless legs, we check to see if they're anemic, and if they are anemic, we want to find out why they're losing blood. Otherwise, we will then look at taking away medications that can worsen restless legs. So the classic ones are the garden variety antidepressants, like the SSRIs, are known to worsen restless legs. Drinking alcohol before bed can worsen restless legs. So we sort of limit those things down, and then we try to make sure we're giving you, particularly if it's happening at night, the controlled release Sinemet in the evening, or a longer acting dopamine agonist in the night. Otherwise, as has sort of been, I think, a little bit underemphasized by me, is the things that you can do yourself, stretching, yoga, stuff like that, is all very helpful. So I'll finish by talking briefly about sleep apnea. which is it's about 4.5% of the general population has sleep apnea. The majority of those are typically obese, and at least one study has shown that almost 20% of Parkinson's patients had obstructive sleep apnea, and they were not obese. And so the thought is that when you're breathing in the night, one thing that happens when you're laying on your back is that your soft tissue in your throat can sort of collapse on itself. And then even though your chest and abdomen are expanding to pull in air, you aren't able to because it's collapsed. And when people have an enormous neck and are significantly obese, it makes sense why that happens. Whereas in Parkinson's patients, the thought is that the same reason you're not as good using your muscles to button your buttons, tie your shoes, that kind of stuff, that those same problems happen in your airway, and they're more likely to happen at night because typically you're more quote-unquote off, or your medicines aren't working as well during the night. That being said, there have been a couple of studies that have recently disagreed with this, and so people are really trying to look into it. Typically, you'll know if you have sleep apnea when your bed partner elbows you in the ribs repeatedly through the night because you're snoring, and particularly if they notice that you're stopping breathing. If you wake up with headaches, you wake up with a sore throat, those are all clues that you may want to get checked out. If it is a cause of sleepiness, it's relatively easy to treat. So typically, if you do think you have sleep apnea, you go to see a sleep specialist, preferably me. You would try to not drink alcohol within 3 hours of bedtime. It's actually relatively dramatic how much of a difference alcohol can make in terms of relaxing your airway muscles and can worsen sleep apnea. Losing weight is always nice, and that will reduce the amount of pressure on your airway. Sleeping on your side is an important thing to do, and in fact, they sell all sorts of devices online now to encourage side sleeping. We used to tell all our patients to sew tennis balls into the back of their shirt so they wouldn't sleep on their back. I have yet to meet the patient that actually did that. And so they sell, these big Velcro humps that you can basically put on your back that keep you from rolling over. And otherwise, we would recommend a therapy based on whether or not you had sleep apnea, either something that pulls your jaw forward to keep your tongue out of your airway in the night. There are surgical ways to treat sleep apnea, though arguably not that effective. And then the most common, and most people have seen this in friends or relatives, is continuous positive airway pressure, which basically is like wearing a fighter pilot mask with air blowing through it to keep your airway open. And it's something that we always say is almost 100% effective. The reality, though, is that you have to be very careful about using the lowest pressure possible to treat patients and let them get used to it. Because even though I used to always say, oh, it's not too bad to wear it, I recently wore it to sleep one night, and it was a horrible experience. So it was somewhat like sort of sleeping with your head out of a car window. So though it's very effective, it is something that we have to take great care to fit your mask appropriately, get the pressures done appropriately, make sure that sometimes we'll set it at different levels so that when you're breathing out, it's easier to breathe out. And so it is something that we take very seriously because it's great if people use it and can fall asleep, but otherwise not. So that concludes my presentation about sleep.